Prior to initializing the procedure, make sure you have reviewed the indications and contraindications for a tube thoracostomy. Also, ensure that you have selected the correct side. Begin by administering prophylactic antibiotics. Cefazole in 1 gram intravenously or clindamycin 600 mg intravenously for penicillin-allergic patients is appropriate. Position the patient by abducting the ipsilateral arm and securing it in place using an assistant or a soft restraint. In the non-emergent setting, consider the use of sedation or analgesia in discussion with the supervising attending. Examples of medications that can be used include midazolam 1 to 2 mg IV or fentanyl 50 to 100 micrograms IV. Next, determine the appropriate insertion point at the 5th intercostal space or the level of the inferior mammary fold and the mid-axillary line. Mark this point with a non-sterile marking pen. This site should be confirmed by the supervising physician and should be no longer than 3.5 centimeters or 1.5 inches. Next, sterilize the lateral chest wall with either a betadine or chlorhexidine-based prep. Now, sterilize your hand thoroughly. Don full barriers protective equipment. Make sure you use double gloves with green gloves on the inside and brown gloves on the outside. Place drapes across the chest to outline the sterile field. Take care to expose the nipple in males and the inferior mammary fold in female patients to act as an anatomic landmark. Now anesthetize the skin and subcutaneous fat with a local anesthetic, for example 1% lidocaine with epinephrine. Using the skin mark as a guide, make an adequate incision. Utilize blunt tissue spreading technique to dissect through the subcutaneous tissue down to the intercostal muscles. At this point, inject additional lidocaine to block the intercostal nerve. Continue with blunt tissue spreading to dissect over the rib, through the intercostal muscles and into the pleural space. Use digital confirmation to ensure entry into the pleural space. You should be able to feel the parietal pleura and lung before continuing. Always remember, the first thing in the chest should be your finger. Now, place a 28 French chest tube, clamped distally and grasped proximally with Kelly clamps, into the cavity and direct it posteriorly and apically. The next step is to secure the chest tube with a zero silk suture. This is done by using single loose perpendicular stitch at the midpoint of the remaining wound, with the loose ends of the suture wrapped and tied around the tube. Ensure that you have secured the tube on the anterior side to avoid kinking. Cut the external end of the chest tube perpendicularly at the point of maximal diameter. Connect this to a closed chest drainage system and an autotransfuser as indicated. Place the drainage system to suction. Apply a dressing made of petroleum gauze or foam, and a white silk tape. Make sure the tube is not kinked and that you have taped it anteriorly to avoid kinking. Obtain a post-procedure chest X-ray to confirm position and treatment effect. Finally, clean up all your sharps and supplies and ensure that both layers of doffed gloves are intact.